Hello everyone. Based on the request of some of you, I will be talking about reverse triggering. I will try to explain it in simple terms so we can understand it and be able to differentiate it from double triggering. I will start by putting double triggering side by side with reverse triggering. And let's start from the left side. You can see that this breath here is initiated by negative deflection of the pressure, indicating that it is started by the patient. What we have here is pressure over time, the middle one is flow over time, and the lower one is esophageal pressure, which is a proxy for intrathoracic pressure. So if you correlate this negative deflection with the esophageal pressure, you will see that the pressure goes down, indicating that this breath is started by the patient. So the machine is triggered here by the patient's effort. And once the machine is triggered, it delivers a limited flow, indicating that this is volume control breath. And you can see that pressure goes up gradually to the peak inspiratory pressure. Now notice along with this inspiration, the patient continues to inhale. Now at this point here, this is where the machine cycles from inspiration to expiration. The pressure is released, flow goes down to zero, and of course, expiration starts. However, if you take a look on what's happening with the patient, you will see that the patient continues to inhale. And in fact, his intrathoracic pressure is even more negative. Now, this negative pressure caused another trigger for the ventilator. So the ventilator was triggered again by this negative pressure here. So the machine delivers another volume controlled breath. It's the same volume. So you can see that the flow is the same. However, since we have this volume inside the lungs from the first breath, then we need higher pressure to deliver that volume. And that's why the pressure here goes to higher level than this pressure. Now at the same time, notice that the patient continues to inhale. However, he starts exhaling at this point here and the pressure goes up. So that's why this pressure is much higher than this pressure, because here this is the transpulmonary pressure. The patient was contributing to the inhalation. But in this breath here, the patient is not contributing to inhalation and the machine has to do most of the work. That's why the pressure is much higher than the first one. So this is double triggering, meaning that one inhalation from the patient caused two ventilator breaths. So one inhalation, you can see a very prolonged inhalation. This is from the patient, and you will see that the machine was triggered twice. This first one, and this is the second one. This volume was stacked over this volume. That's why sometimes we call it stacked breathing. So this is double triggering. Now let's move to reverse triggering. On the right side here, take a look on the esophageal pressure, and this is where the first breath is initiated. You can see that there is no negative deflection and the machine is triggered. If you correlate this with the pressure, you will see that there is no decreased pressure compared to this one. So the pressure did not decrease inside the chest, indicating that this breath is time triggered. This is machine delivered breath. And this breath is actually pressure control. You can see the pressure goes up to a certain level and stays at this level. And you see that the flow is decelerating flow. Notice that the pressure inside the esophagus is not changed. Okay. And then exhalation starts here. The pressure is decreased or released, and we should have exhalation here. Now notice that we have this increase in the flow. So the increase in the flow here is any positive flow indicates that this is inspiratory flow. And if you correlate this with the esophageal pressure, you will see it is happening at the start where the esophageal pressure is started to decrease. So the patient here looks like there is an inhalation. So this is a negative inspiratory effort by the patient. However, it is not caused by the firing from the respiratory center. It is caused by the ventilator breath. So the positive pressure of the ventilator caused contraction of the diaphragm in a complex mechanism. We call it entrainment, meaning that the patient's intrinsic respiratory rhythm is taken over by the periodic mechanical insufflations of the ventilator. So the patient's intrinsic respiratory rhythm from the brainstem or from the brainstem respiratory centers, this rhythm is taken over by the periodic mechanical insufflations of the ventilator. So this breath is the one that triggered the contraction of the diaphragm. Once the diaphragm is contracted, and it could be also other respiratory muscles, you will see that there's a decrease in the intrathoracic pressure or the esophageal pressure, as you see. Now, the drop in the pressure may not necessarily trigger another ventilator breath. In this example here, the drop in the intrathoracic pressure was low enough to trigger another ventilator breath, and the machine delivered a pressure controlled breath, same pressure as the previous one. However, the flow here is higher than the flow in the first breath. And the reason being is because transpulmonary pressure, which is ventilator pressure or plateau pressure here, minus the intrathoracic pressure, is higher than the transpulmonary pressure of the first breath, because there was no decrease in the pressure by the patient here. This drop in the intrathoracic pressure is caused by contraction of the diaphragm. It may be associated with contraction of the respiratory muscles also, or the inspiratory muscles. It is not caused by firing from the brainstem respiratory centers. Now, if you want to compare reverse triggering with double triggering in terms of initiation of the breath, the first breath here is initiated by time or triggered by time. It is machine initiated, compared to the first breath in double triggering is initiated by the patient. There is no inspiratory efforts of the patient during the first breath. In double triggering, there is inspiratory effort, and this is coming from the brainstem respiratory centers of the patient. The second breath could be triggered by the drop in the intrathoracic pressure, which is caused by the contraction of the diaphragm from the first breath. The trigger of the second breath in double triggering is caused by continued inspiratory efforts of the patient. So I hope this is clear, but I will give a couple of examples to clarify this in more details. So I had this patient who is 58 years old, history of diabetes and hypertension, admitted with pneumonia, respiratory failure, and ARDS. Intubated on mechanical ventilation. He was on fentanyl and propofol, but his RAS score was -1 to -2. So the nurse calls to evaluate ventilatory dyssynchrony. And without going into the details of hemodynamics, oxygenation, ventilation, and respiratory dynamics, I just wanted to mention that he's on PRVC with a targeted tidal volume of 470, a respiratory rate of 28. So let's take a look. You will see that this is the first breath. I don't see exactly how is it started. The second breath here, you don't see any negative deflection, and the third breath, you don't see any negative deflection. And at the same time, the machine did not indicate that this is started by the patient. So I assume that those are time-triggered breaths. And of course, the rate is 28, so a bit over 2 seconds, and that is exactly what's happening. These are all time-triggered breaths. Now, the flow goes up to peak inspiratory flow and starts to go down. However, at the end of inspiration, you see here that the flow is pushed up. This indicates more inspiratory efforts. You can see that the pressure is not increased. So how did that happen? It must have happened by contraction of the diaphragm and respiratory muscles, indicating that there is more inspiration. Now the time-triggered, time-cycled breath is finished here, and the pressure is released. The flow goes to expiration. However, it pulls back again because of inspiratory efforts. And you can see here, this is the tidal volume starts to go out and then stops here because of this inspiratory efforts. So now this inspiratory efforts did not trigger another breath, but we see that there is inspiratory efforts here, another one here, and every single breath is followed by inspiratory effort. So I was thinking that since those are time triggered, this is machine triggered, and this is happening right after that, it must be reverse triggering. However, I need to confirm this. And if this is caused by reverse triggering, there are a couple of maneuvers that you can do to confirm. Number one, slow down the respiratory rate. If you slow down the respiratory rate, since those are caused by contraction or by the positive breath from the ventilator, so they will go down also at the same rate. So that's one thing you can do. What I did in this case is I put an expiratory hold. So this is beep of 12. We put expiratory hold here. And if you hold inspiration, if you hold in expiration, there's no more ventilator breaths. So what happens? You should eliminate any reverse triggering. And in fact, what you see here is there's a breath here, there's another breath, and a third breath. And take a look on the rate. You will see that it is every 2.3 seconds or 2.2 seconds probably, there's a breath. And those are exactly the same one that we were seeing before. So that confirms that these inspiratory efforts are not caused by reverse triggering. And in fact, they are caused by patient's spontaneous efforts. Now, one more thing I did, I put an inspiratory hold. Also, you can see the pressure goes up to 30. I put inspiratory hold here, and the same thing happened. This patient continued to breathe on his own. So those were patient's spontaneous efforts. It happened that the rate of the spontaneous efforts following the ventilator-delivered breaths. And what we did in this case here, we increased sedation for the patient. This is exactly the same patient after increasing sedation, and you can see that this was completely eliminated. Now, of note, you should know that deep sedation usually is associated with reverse triggering. And in fact, the only way you can eliminate reverse triggering is by either decrease sedation, not increase sedation, or if you cannot decrease sedation, at that time you need to paralyze the patient. Now, the second example here, you can see that this patient is on pressure control mode of ventilation. The rate is set at 14 per minute. The pressure is 8 centimeters of water above PEEP of 10. So take a look here. We have 2 breaths here and 2 breaths here. So look at these 2 breaths here. The first breath is time triggered. You don't see negative deflection. You don't see the indicator that this is started by the patient. So this is time triggered. The machine delivered 8 centimeters of water above the PEEP. You can see the flow goes up to maximum inspiratory flow and decelerates, and the volume was around 400. Now, expiration starts here, and this is time cycle. The pressure goes down, and the flow goes down to expiratory flow. Now notice that I don't see an indication here on the flow that there's inspiratory efforts. However, you see that this is patient triggered. The pressure becomes negative here and was low enough to trigger another breath. And you can see that expiration starts here, another inspiration starts here. So the question is this caused by patient's inspiratory efforts, spontaneous efforts that happen to be right after this breath, or is it caused by contraction of the diaphragm because of the ventilator breaths here? In order to answer this question, I need to slow down the rate. If I slow down the rate to 8, for example, you should see that the second breath will follow the first one at a rate of 8. Unfortunately, I don't have a confirmation of this, but this is how you want to confirm whether this is reverse triggering or double triggering. Of course, it is cannot be called double triggering because you don't see an inspiratory efforts here. So if anything, this would be inspiratory effort of the patient happening after each breath. That's why I suspect it is likely to be reverse triggering, but I need to slow down the rate to confirm this, or put an expiratory hold. If you put an expiratory hold and this pattern continued in a way that you still see inspiratory efforts of the patient, that confirms that this is not reverse triggering, but it is inspiratory effort of the patient. I do have a couple of other examples. In the next one here, this is reverse triggering. You can see that this is volume control mode of ventilation. The pressure goes to the peak pressure, and then you have a plateau. And in the plateau here, you should see zero flow, and that's what you see here. Now notice what happened here. The pressure is dropped, and the volume in the lung is the same. How the pressure would drop if the volume is the same and the flow is zero? This is a plateau pressure. I need a plateau pressure to keep that volume in. So the only explanation for this by inspiratory effort of the patient. So you have inspiratory effort of the patient that caused this drop in the plateau pressure. And that inspiratory pressure continued. This is expiration time cycled goes to expiration, and this is another increase or decrease in the flow, in the expiratory flow, indicating that there is initiation of inspiration here. Now, again, I don't have the confirmatory test, but this is confirmed to be double triggering. The rate was slowed down, and those inspiratory effort followed the drop in the rate. If you put expiratory hold on the patient here, you should not see this anymore. Another case, this is pressure control mode of ventilation. You can see at end of inspiration, there's something to indicate that there is contraction of the diaphragm or inspiratory efforts here, continued into early expiration. So this is contraction of the diaphragm, exactly the same thing, exactly the same thing. We slowed down the rate, and that followed exactly the same rate of the ventilator respiratory set rate. So that confirms that this is reverse triggering. Now, the only problem with reverse triggering is that it may cause more lung injury, especially if it caused double triggering like this. Again, the reverse triggering may not necessarily trigger another breath, but if you have double triggering like this, this is against protective lung strategy. Like in this case here, you ended up putting close to 1.2 liters of air into the lungs. So in protective lung strategy, this would be injurious. The other problem with reverse triggering is that the diaphragm will be contracted in eccentric way, and that will cause turbulent flow, or what we call Pendeluft, or movement of the air from one region of the lungs to another region. This would cause more lung injury in patients with ARDS. I hope I was able to give you a clearer idea of reverse triggering compared to double triggering. If you have any question, please put it in the comment section. Thank you.